Hello, everyone. My name is Judy. I'm the Director of Marketing here at Mocingbird. Great to meet you all. So I want to encourage everybody to drop your name, what you do, your location in the chat box so people can connect with you during and after the event. And the other part would be if you have any questions for our speakers, please drop them in the chat box as well. And we'll definitely try to answer as many of them as possible at the end of the event. We are around 10 minutes past, so we're gonna get started. And if you have friends that are joining us, definitely give them a shout out and have them join very soon. We're super excited to have 3 amazing speakers to share their insights on the future of the trend of healthcare. On our panel today, we have Dr. Ian Madom, the co-founder and chief strategic officer at Mocingbird. He's also an orthopedic spine surgeon. We have Dr. Paula Muto, the founder and CEO of UBERDOC. She's also a vascular and general surgeon. Very, very impressive. Lastly, we have Dr. Girnita, the founder of Rheumatologist OnCall, who is certified in rheumatology and holds multiple state licenses. So she will be able to share her experience as a telehealth doctor and what is it like to maintain multiple state licenses and see patients across state lines. So all very relevant discussion. Now I'm going to give the stage to Dr. Ian Madom as he will kick off our discussion tonight.
Well, thank you everybody for joining us tonight. I'm really excited about this topic, obviously for what I do, but also the 2 people that are joining me, both Paula and Deanna, are going to share a lot of their insights as to where telemedicine is bringing us in the future of medicine. So Harvard Business Review has basically said that in a few years, it's going to be a quaint idea that we will receive our medical care in a doctor's office or in a hospital. That kind of sets the stage for where people are thinking about telemedicine. And we have different ways of going about this, either through a traditional telemedicine platform or platforms that Dr. Muto is offering and Dr. Girnita is offering. So I would just like to open up with a question to both of them. And it's more of a reaction to some of the people's thoughts that are out there. So the CEO of the American Telemedicine Association, Jonathan Linkos, he said that in an age where the average consumer manages nearly all aspects of life online, it's a no-brainer that healthcare should be just as accessible, convenient, and safe as online banking. Thoughts about that as we open up? Paula?
Okay, sure. I'll start. So yeah, convenience. Convenience is part of every aspect of our lives because of technology. It is exactly the opposite when it comes to medicine. I mean, if you think about it, it was really convenient when you had a neighborhood doctor, right? That kind of was the person you went to when your child was sick, and then they referred you to the specialist if they needed it. It was pretty convenient and easy. And that mode of medicine is now, it's like 100 years ago. Everything has become so much less convenient. So I do think that, so convenience is of paramount importance because patients really don't deserve to be delayed. And when patients are delayed, we see bad outcomes. I think that the question is, why we need something like digital health or telehealth. And obviously COVID kind of brought it all accelerated, is because we have to make it easier. We are just looking for a simpler solution for patients and doctors to connect and using technology to do it. And I think that I think any physician in any stage of their practice has to include a telemedicine examining room. You just have to have that in your practice moving forward. It doesn't mean you abandon your patients. It doesn't mean you're completely virtual. I think any practicing physician needs to have the capacity to do both in-person and virtual care. Diana?
Yeah.
Yes, I have to agree with you, Paula. And I have to say that I'm very excited that people embrace telemedicine so quickly. Unfortunately, we had to go through a pandemic to have that approval. I started to look into telemedicine in 2018 when I realized that we all carry in the pocket a very incredible tool, our smartphones. And we were very comfortable to do everything, manage our finances, manage our way to work, manage our, even entertainment. We entertain with our phones. We do, basically we live our life through our cell phones. And I've lived to see patients struggling to get for an appointment. And when they had that opportunity to come to an appointment with a specialist, we had too little time for that. So basically, I was seeing patients wasting half of their day to see me or see another specialist for about 10 minutes. So that didn't seem right to me. I tried to incorporate that idea in the practice where I was, but because it was not reimbursed in any way, I had a huge resistance regarding that. So we have to accept telemedicine as an open door to access for patients. And when we think globally, telemedicine opens up this collaboration with other physicians internationally, or give options to patients across United States, not to think about patients that we have here and they don't have access to us, but think about also patients that they are, abroad and they have probably less than what patients from United States have.
So just as a follow-up to that, because it sounds, yes, the pandemic, that kind of forced a lot of us into workflow changes and changing our practices. What practice changes did you have to make telemedicine a part of your daily routine? And I guess which ones were the low-hanging fruit? What was the easiest ones? And then what were the biggest challenges?
So I think that, we should define what we mean, first of all, by telehealth, right?
Yeah.
Because I think that during the pandemic, they were reimbursing for not a video conference necessarily, but a telephone call. So we've all in practice have always called our patients. It's part of the deal, right? You do a breast biopsy, you call the patient with the result. You do it, patients call you with a post-op question or pain, you answer that phone call. So you have to kind of think of those encounters. During the pandemic, you had your chronic patients, your own panel of patients that you needed to connect with. So telemedicine became part, you just turned your E&M codes, your routine office visit of a follow-up patient. Instead of doing that in person, you immediately shifted, you gave them the option of doing it via either a teleconference, telemedicine, or like I said, in a lot of cases, a phone call. These are what I would consider, these are visits that are planned visits, elective appointments that are being made. There's another part of telemedicine that I think people think about, which is like a doctor on demand. I need to talk to a doctor right now, and I don't know who to talk to, and I don't want to go to urgent care, so I'm going to call this number, or I'm going to go online. Those are like those synchronous visits, and I think that isn't where 90% of the doctors lived in this transition during the COVID epidemic. I think that so we kind of have to think about what we're discussing, because a lot of people have that impression, telemedicine is like that. Oh, I need a doctor right away and I can just go online and find one. But realistically, most of telemedicine in the last year has been your neighborhood doctor, your chronic specialist that is in interacting with you in a virtual manner instead of in person. And I think that is an easy transition for most of us to make, because we just had to figure out how to use Zoom like the rest of the world, and or something that's HIPAA protected. And frankly, it just, in my office, we put aside telemedicine appointments and we were able to see our patients like that.
I mean, that's why the insurance companies said that they weren't going to reimburse them except for rural areas, right? Where people didn't have a doc accessible. Deanna, the model, at least based on what I'm seeing from your, your company that you've started is Doctor on Call. So do you have a combination of these two types of patients that Paula is talking about? And how have you set up your practice and changes that you've made?
So last year, I practiced primarily via telemedicine. There were two types of patients that needed to be seen and they were never been seen before, and patients that require chronic management. In rheumatology, probably 80% of our practice is based on chronic management. We manage medication, we review labs, so that could be very easily done through a televisit. The other type of patients that they needed to be seen are usually patients that they have a flare-up from a disease like rheumatoid arthritis or gout that needed help right away. And they didn't want to travel to an emergency room or travel to the urgent cares, and they wanted to be seen right away. So I was able to provide them that kind of support right away. And it was extremely convenient for the patients because the evaluation can be seen, can be done virtually, and the management can be addressed also in the same way. There were very few patients that they needed to be directed to the hospital, and that saved them time, money, and it was extremely convenient. And they had to cut that time of waiting time into basically one day, or I was able to provide visits in the same day, which is unheard for the traditional system, where you place a call and then you wait for a nurse to call you, and then you wait for the doctor to call you next day, and maybe you get something, or maybe you are told, we don't know what to do with you, we cannot see you, go to the urgent care. So this type of patients can be very easily managed through telemedicine.
So I did some telemedicine when when we were all in the middle of the pandemic. I have had a harder time as a spine surgeon bringing it into the regular part of my practice, because I have the challenge of, I'm not sure how to get the physical exam part right. What are ways that you both have overcome that part and changing just the way you interact? And a lot of that may just be the way that I'm thinking about what the interaction should be, right? How have you both managed that?
So that's kind of interesting, because as a surgeon myself, as well, there were certain things you just don't do with telemedicine. One of my breast patients, for example, annual follow-up, it's like, okay, I've got to examine you. We can talk about the results of your mammogram, but we need to examine. But I've been doing, I do vein screens. I have patients that come to me with, venous disease. I have, when I'm in the office, I have supersized posters behind me, the same ones I have in my office, in my examining rooms, but I made them really big. So I can explain the physiology and explain kind of the anatomy. I ask the questions, and from the conversation, I get their complete history, and I just know exactly who they are. And, because the disease is inherited, I know if they have restless leg, I know who they are and whether they are going to need an ultrasound, or whether they don't need an ultrasound, or they just need to be seen and maybe an injection. I can tell that from the history. Now, when I try to look at those patients, it's impossible. They show me their legs, they fall off their chair. It's not really ideal. And I don't expect that to be part of my evaluation in a brand new patient. So I think that you have to rely on your history taking, your experience. Most of the time we can figure it out by asking the right questions. So I think that you have to just decide what your limitations are. Now, if you're doing behavioral health, if you're doing like Dr. Girnita, she's probably the best doctor in this country. I'm going to say that. My family member saw her and said, this is the best doctor I've ever seen, because her knowledge base is so huge and her experience is so, to tap into her with your symptom complex. Does she really need to lay her hands on you, to understand what your story is, right? Because you've been dealing with a chronic disease for years, right? And so I think that that the value of telemedicine, the excitement is that collaboration, is that ability to transcend state lines, transcend networks, get the patient to the right doctor as quickly as possible, and to use that. And in terms of just your own workflow, I look at the busy orthopedics. They have hundreds of patients in the waiting room. Can't some of those patients be quick follow-ups, and can't some of those patients be virtual? It's really just, how are you doing? Is your pain under control? Are you full range? I mean, I understand you got a lot of x-rays, there's no question, but there's probably some creative ways that you haven't thought of yet, to be able to, you know, lighten your waiting room and just reserve it for patients that need to be seen. Because a lot of times these waiting rooms have 90, 100 patients in them, and they come in and you're there for 3 minutes, and the poor patients are waiting for a really long time. So I think that we've got to meet our patients halfway.
Yeah, I think you know, it's based on specialty. Not all specialties could be applicable fully to telemedicine, and we have to be creative. Fortunately for rheumatology, our assessment is, you know, very intellectual. We pair the history, and we tend to take a very detailed history, and we pair that with a lot of labs, a lot of imaging, and also physical exam can be done. I would say a proper physical exam can still be done via telemedicine, even in office. When I was doing physical exam, I was basically pointing to the patient what kind of motions he has to do to test the range of motions of different joints. Now, that's also very dependent on the pathology that the patient presents with. And if there are things that are pretty complicated, let's say you are dealing with someone that you believe they have vasculitis, that's a case that you have to move to the hospital. You have that feeling, you understand that you know the acuity of the case, and in time I developed these networks of physicians where I plug the patients. I'm able to pick up the phone, but that's something that is based on my collaboration with other physicians. You pick up the phone, you tell them about the patient, and they will plug in the patient to the next day, or, you know, will admit the patient in the hospital. I try to restrict my areas of practicing where I have connections because of this. You know, there are very rare cases, but you want to be prepared for those rare cases to plug them in somewhere. Because those patients, even if they wander around through other specialists, they will lose very, very valuable time. And by the time that we'll get to see the specialist, let's say you have a patient with vasculitis, but he cannot be seen in the next 4 months. 4 months, he could be dead in 4 months. So, you know, you just have to base your assessment on your experience and the interaction with the patient. And when you have a lot of time with the patient, and availability to see the patient again and again, that's easier for you to figure it out. Because when you have in a visit, when you have 10 or 15 minutes with a patient, you're rushing. You are rushing to put some information in the computer. You are rushing to look at the patient. And that's why I broke that time limit. And I start with 60 minutes. And if I need more than 60 minutes, I can expand that time. But that limits the number of patients that I can see in a day. But that brings the patient a lot of value, because instead of giving them or feeding them a paper and they figure it out, you have the time to spend with the patient and educate the patient about the next steps. And the patient has the comfort to know that you are there. I mean, if the visit is done, but he still needs to talk to you, he can shoot you a message, and that message will get to the physician, not wander around through 10 different filters until the message gets to you. So I think that kind of communication with the patient is crucial in our profession.
Yeah, I just want to say that I think that that Dan is touching on something so important that's critical and integral to most doctors probably on this call and the way we practice, and that's we are colleagues, right? We don't manage patients individually, especially specialists, right? You manage patients as a team. And I think that what we're trying to do, especially with our UBERDOC model, is to just encourage doctors to embrace telemedicine, not as not to become like I would say like a teledoc that you're just visiting that one time, but to embrace in a community of doctors that creates a referral network, you know, and again, within state lines, locally, using the telehealth as a digital tool to facilitate a patient's care. In any way that that could be, but working as a team, I think, is so important. And the more doctors, you know, every day practicing physicians in the front lines, taking care of patients, adopting telemedicine, that's how this is going to work. And the opportunities then are endless. And I think that that is such a smooth way to transfer patients and to talk about patients' care. And I think that that's really important that we stress that we're physicians taking care of patients. That's what we do. And we're not like, you know, just answering a quick call for a stranger patient and, you know, just answering the call and hanging up the phone or whatever, and just, you know, a 10-minute one-off. I don't think that's where the future of telemedicine is. I think it sits right here in the tools in the hands of physicians in practice every day.
So, I mean, I think those are all great points. And I think that's what I'm hearing is a great opportunity even to start designing some education for our colleagues around how to do this, right? Like, it's not just picking up the phone. It's not just turning on your Zoom camera. There's a lot of other pieces involved with getting yourself set up to do telemedicine visits, to be prepared while you're sitting in that chair. So, you know, I think that the three of us would agree that there is a strong future for telemedicine, and it will probably evolve as time goes on. It already has. What are the main blockers for the docs, right? Who are doing this? Because you would think it would have taken off even more, but there's been a little bit of a pullback, and I'm wondering what your thoughts are on why more people haven't said, you know what, I'm going to go to this as being the majority of my practice or a much bigger part of my practice. What are some of those blockers that you both see?
I think the first blocker is revenue, right? I think it wasn't a reimbursable event. I think that it is reimbursable now. I still don't think that's enough of I still think there's an obstacle. You can't collect a copay from a virtual patient. You can't order the EKG. You can't order the blood test. You can't do whatever upsell that you might be doing with the patient, right? Well, all the other things you did with the patient to kind of make up for what you weren't going to collect. So I think that that's still an issue. It's one of the reasons why I think telemedicine is efficient and inexpensive and should sit in the cash world. I think it could be like higher than a copay, but less than a visit, somewhere in there. I think for some offices, it would be much more efficient to do it that way. I think the other thing is technology. Doctors are afraid of technology. They gave us some electronic records and we're like, oh my God, now I have to do telemedicine. What's going to happen? I think the office front ends are reluctant. When my office was a little bit, are we really doing telemedicine? Now it's easy for them. They just send the patient the URL. It's much easier than mailing them the address and the time of the appointment and so forth. And so it's easier for them, but it was something that they were first a little reluctant. So I think those are the two issues I see, the money and the technology. Both of those issues are easily surmountable. And I think that practices I think new patients especially, it's going to be much easier to see a new patient via telemedicine through a cash model, as opposed to try to collect their insurance card.
Yeah, I have to agree with Paula. One is on the physician side, adopting novelty. I think it's always hard for any human being to get used to something new. It needs time. And the fact that it was not reimbursed was pushing back on a lot of physicians. The other thing is the patients. Physicians think that patients want to be touched, and That's the connection that will make everything possible. And on the other hand, the patients are so used to technology, and depending on the age group, but I've seen, very young patients via telemedicine, but I've seen patients in their 80s that they figure it out to be seen on telemedicine. And once they see how convenient it is, patients will come back and will request to be seen by telemedicine most of the time. There are times when they want to be seen in the office, but most of the time they appreciate that convenience. For them to be able to don't set up the time, an hour to travel, an hour to spend in the waiting room, an hour uh, going back to their house or arranging stuff for what am I going to do with my kids at this point until I go to the doctor. That's extremely valuable. So instead of spending 4 hours for a visit in a day, they spend 30 minutes, an hour, where they have all the attention of the physician on them. And I think that in time, people will, both physicians and patients will adopt that as a normal. They started to look at telemedicine as a normal way of seeing patients. And I see more and more physicians that are calling and asking me, how am I going to do this? What do I need to start a practice like that? It wasn't like that 2 years ago. When I started to look into this, people were looking at me like I was chasing a unicorn, and it was very hard for them to understand what I'm looking for. It was even hard for me to find a lawyer that will understand what I look when I start my company. And that took time, but now the resources are here. If you want to start something like this, I'm more than happy to help people, but there are a lot of resources available for those that are interested in telemedicine.
Yeah, the technology will certainly catch up too. I can foresee a day where the Internet of Things kind of knows that I'm going to have an appointment with my internist, and a drone shows up with a device that I put on my chest, and they can do a more in-depth exam or send information. That's coming, right? We're not there yet. But we're closer than we think, right? Seeing that little device that you were talking about, Deanna, only came out about 12 years ago, the iPhone. So I think that from where I sit, my interest in all of this, as a physician, certainly I'm always focused on what will benefit my patients, but I also have this focus on the physician experience, or all clinician experience. And I think that, it can be a challenge to say, well, I'm going to do telemedicine and widen my scope. I can do it in Rhode Island or Massachusetts or Connecticut. Well, there's opportunities that are out there to go beyond that. The second opinion market, I know, Paula, you have some thoughts on that. And even just a market beyond, where you might be locally. But there's some challenges there when it comes to licenses and managing multiple licenses. Have either of you felt that pressure? I know that, Deanna, you carry multiple state licenses yourself. So just threw a lot out there. Any thoughts on both of those things?
So there's a practical issue, right? Certain specialties, it doesn't make sense to have multiple state licenses. It's like, for example, I have a license in Massachusetts and one in New Hampshire, because New Hampshire's 10 miles from where I am, and there's a surgery center up there and so forth. But it's impractical for a surgeon, for example, to have, you're not going to be traveling around, multiple states, because your expertise is really is local. It has to do with what we do with our hands in the OR. Now, that being said, Dr. Girnita is an expert. So we would all want to have her expertise, because her expertise is something that she can convey to us and across state lines. The challenge now becomes this point of care follow-up, right? Who's going to do the care afterwards, right? If you and I go to another state and operate and then go back to our home state, right? And the patient has a complication, right? It's impractical. I've always said, some of these crazy plans, employer-based plans, which say, oh, we've made a deal with, the Mayo Clinic, and you're going to go to Mayo Clinic for your gallbladder surgery. It's like, you live in Florida, but you're going to go across to another state. Actually, there's a Mayo Clinic in Florida. I take that back. But you live in another state. It's like it makes no sense, right? Because the care of a patient and the post-operative management and the family that you need. Remember, patients recover at home with family members. You disrupt that whole continuum, and it does. And your outcomes aren't going to be good. So we have to remember what medicine is, right? It's local, it's regional. Now, when you talk about that second opinion, if you are looking for a second opinion for a treatment of a cancer or like a melanoma, and there's the one person in the country that's so good at melanoma, and especially with the types of tumors, the way we're just diagnosing them now at the genetic level, you want to talk to those experts, but do you want to fly? Do you want to go all the way across the country? Is there a way that you can have that visit virtually? And if the doctor isn't outside state lines, that's where you can have a point of care doctor present. Like, in other words, if you have a local oncologist with the patient, then you can go outside state lines for that second opinion. So there's a little wiggle room there. I think that we don't know what's going to happen, the shades of gray, but the rules have to be very carefully followed, because if you try to practice medicine beyond your state lines that requires chronic care, and you're not licensed in that state, I think you're in a slippery slope, right? I think that's where it's going to break down. We're working with international consultations, but it's pure point of care. In UBERDOC, we have an UBERDOC India pilot. We have doctors in India who are taking care of patients, point of care, who want American experts to weigh in on a cancer diagnosis, on liver transplantation and what. And some of these patients might in fact take the flight, but more importantly, they're just looking for that reassurance that, that they're getting the same treatment as somebody in New York City is getting for their breast cancer, or for, they just need that reassurance. But that's international telemedicine has to also follow the rules. You cannot recommend a treatment that may not be approved in that country, but you can give an opinion to a doctor at the point of care and say, I concur with your, or this is what we're doing in our country. That's about most you can do. So there's a practical issue to all of this. It all sounds great, but sometimes you have to really put yourself in that patient's shoes and what's going to be practical to get them better.
Deanna, you have a lot of licenses. How does it work out for you?
I have license in 6 states in the United States, and I have to tell you that it's extremely challenging for a physician, despite being trained in the United States, despite following a residency program which probably meets the same curriculum everywhere in the United States, to get this license in other states. It's an archaic way in which they work. They ask for the same documentation all over again. So, and they ask for the same questions, and you have to prove that you never had anything, any malpractice in any of the states that you have been working to be approved in a new state. There are a few companies now that are trying to use blockchain technology, and they try to create some digital passports for physicians. I actually gonna tell you that I was very excited when I heard about one of those companies. I actually invested in that company. So excited I was, because I know how stressful it's to go through the process, and not only to go through the process, but also keep up with the demands that every single board, medical board has, because they are different. It doesn't matter that you are here practicing here for 15 years. Sometimes they change the demands, and you have to keep up with those requests from the medical boards. I do not advise anyone to practice outside of their area of licensing, because as Paula said, that could be very, very tricky. And in terms, somebody asked about malpractice when we started the meeting. There are ways for malpractice insurance to cover you just for telemedicine. Now they have a separate section for that, which will cover you from multiple perspectives, even for cyber security. They will offer you cyber security as well. And on the other hand, I believe that, as Paula said, the fact that we have licenses in multiple states kind of opens the access to us, and this is great for patients. But again, you have to make sure that the patient who's calling you is truly in that state and is not lying to you that it's in another state, because at the end of the day, you are responsible for that. The patient is not. So I would be very careful when you deal with this kind of matter.
Yeah, Dr. Chaudhry asked in the text stream, is there drawbacks to having in multiple states? I think you guys kind of laid that out. And obtaining those licenses can be challenging. You know, Deanna, we got to get you on Mockingbird because once you got the license, then that's what our whole platform solves for, is when you have these multiple platforms, that has been a challenge for people with their boards, with their states. I tell a story that 3 years ago, when the state of Rhode Island came out with their opioid requirement of 8 hours, and I found out on Memorial Day weekend when my application was due June 1st to get reappointed on the 30th, I spent Memorial Day weekend doing opioid training that had nothing to do with orthopedics. So I think that is one of the challenges, is when it is in this new world, and hopefully we can kind of open up our geography a little bit, both for the patient, but also for us to kind of free ourselves to be able to work wherever we want to work, and focus on ourselves and our ability to, you know, to do our craft in wherever we feel like we want to do it and not be beholden. But for the time being, when we have these multiple certifications and licenses, at least the platform that we've built kind of works really well to complement what you two are doing to allow providers to continue to do the work that they want to do. So I want to leave a little time for some questions for everybody, but I do want to kind of close in saying, you know, as you're both, you know, in the day to day, right? We're busy. We're just trying to take care of patients. What's a bit of advice that you have going forward, like over the next 10 years, in being nimble and being able to pivot and develop your practice in a way that is both fulfilling and also gives the best care to patients? What's some advice that you have to throw out there?
I would say have confidence in yourself. We have doctors are so low now, right? I mean, we don't believe that we're respected. We don't believe, you know, I mean, there's just so much that we feel like no one's listening. But this is such an amazing moment when you're given technology and you're removing the middleman. You can have an intimate encounter with your patient, just your patient. You don't need a cast of thousands. You don't need to have like the way, you know, the receptionist and then the medical assistant, and you know, honestly, to do telemedicine, to see a patient in your virtual examining room is very intimate encounter. And I think that is a gift, honestly, because what we do is we like our patients, right? Most doctors really this is why we did it, right? To hear their story, right? We're story listeners, right? We want to fix their problem. So this is a really wonderful opportunity for doctors to kind of take charge of their practice, to create new lines of revenue that they might not have had, right? Offer their expertise to patients either within their community, within their state lines, or maybe even multiple states, depending what they do. And I think that's like of critical importance. We can keep doctors in practice longer. We had a retired doctor that joined us that has probably, 20, 30 years experience I would be able to answer a question pretty quickly about symptoms, I'm sure, and would be able to at least triage or advise that patient what they should go next. And I think that's of critical importance. I think we have a lot of women who have dropped out of medicine. There's like a 40% dropout rate 6 years after training because of either economic or family demands. I think that being able to keep people in practice, the stay-at-home doctor could be a reality because you can keep the economics of a practice going and not have to make those hard choices of which spouse stays home, which spouse goes to work. I think that medicine is no different, and we could be really flexible, keeping people with experience practicing, keeping people well-trained in practice, creating a model that's better lifestyle for doctors. Doctors have huge burnout. Men and women have tremendous burnout. And I think that being able to say, hey, maybe, you can have an office that operates 3 days a week and 2 days a week remotely. I also think for private practice doctors who want to move away from the big box stores, this is a fantastic opportunity to do that. And your overhead comes down significantly when you run a digital office. I know young doctors who run their entire office off their phones. I think the new generation is going to eclipse us. I'm going to tell you this right now. The younger people are so high tech. You can imagine that next young orthopedic is going to be like managing his entire or her office off their phone. So I think that we're at a watershed moment. We couldn't get any lower than we were as physicians in terms of appreciation, revenue, everything else. But this is our opportunity to reassert ourselves in a very personal way, to become autonomous again. It could complement a practice that's employed. It could become your retirement. It could become your entire practice. I think that there's no question this technology needs to be embraced in some way, and I think it's a game changer.
Yes, I have to say that Paula hit most of my points as well. I think that we as physicians, we are a generation of physicians that are burned out 4 or 5 years into practice, and we burn out, which is unheard. And this is an opportunity to regain your freedom. It's an opportunity to do medicine again. It's an opportunity to connect with patients in a real way. And as Paula said, it drops out of the cost, the overhead is low. The time that you spend with the physician is not dictated by productivity models. It's dictated by the quality that you can offer to the patients. And the fact that you are there when the patient needs you, that's also something that is not happening as we were expecting in the traditional models. I will tell you from my experience, it gives me the peace of mind that I can see a patient while I'm in vacation. So if a patient needs me and I want to travel somewhere, I can still see the patient from that location. So that's nothing compared to, that could not be done in the traditional model. I think that patients want innovation to happen in medicine. They were waiting for years to see that happening in medicine. I think now it's our time as physicians to deliver that to them. And patients are ready, so don't be afraid of that. Patients are looking for solutions. That's why they ask Dr. Google all the time. The fact that patients go and ask Dr. Google instead of coming to you is that because they don't have access when they need it. And of course, they end up in the tragical, critical situations, and they think they're gonna die before they come to you. But this is something that needs to be changed. And what I tell people that are calling me is that don't be afraid. You're gonna fail and you're gonna learn, and don't be afraid to be told no, because no means an opportunity to know someone, and maybe later you can collaborate with that person. So through this whole year where I was participating in a lot of meetings and meeting a lot of people, I've had the opportunity to see so many physicians that are open-minded. And I want to point out here, physicians that are innovators, physicians that they want to change things for patients. And I believe from the bottom of my heart that we are innovators because we try to find solutions every day for our patients. And our place is here in the digital world to contribute to this digital world and to bring it forward in our benefit and also the benefit of our patients.
Well said. I'm proud to have shared the stage with two incredible innovators in the space. I think that you guys are doing great things, and I learned quite a bit that I will start to try to apply to my practice starting tomorrow. I'd like to open it up to any questions. I've been trying to follow some of the questions on here. One that I saw a little bit earlier was, how can you confirm that a patient is indeed calling from a particular state? Any advice on that?
Yes, the way that I do it, I ask for an ID for the patient all the time, and you can easily check, on Zoom, you can see where the patient is located. There is an IP that you can verify, but I also ask the patient to sign a contract with me where they provide, they spell it out that they are residents of those states. So if something happens, that could be both, he's liable to, because he didn't disclose that to me. But those things has to be very well spelled out in the contracts that you made with the patient.
On the UBERDOC platform, you have to put in your state, and then you only see the doctors licensed in that state. Mm-hmm. So that we do it by where we grab their location.
And it is something that, at least what I've heard, best practice is when you are documenting, that you should document that both you and the patient were present in that state, or if you're there, wherever that patient was present, if you have a license in that state, that you should document as well. Somebody was asking me about how I obtained DICOM images for my initial visit. When I was doing some of this during the pandemic, we were having patients send the images to us and loading them into our system. It was very clunky. So I haven't figured out a good solution to that. Any thoughts on that, Paula? Do you ever have to deal with initial imaging on a new patient?
So you mean through the UBERDOC model, or just through in our telemedicine? So our telemedicine partner has uploadable, you're able to upload images. But there are some really cool innovations, and I have to do a shout out to this company called Radionome. They're two physicians, brothers. I think one's an interventional radiologist and one is a radiation oncologist. And they were trying to solve the problem of when you need x-rays and you have to carry them from office to office. And so they have a very nice app where you basically store your x-rays, and it is with blockchain technology. So it kind of alleviates that issue of privacy and so many things that blockchain kind of gets around. So they have an interesting model there, I believe in New Jersey, that patients who have a lot of x-rays, they want to do what they call the Netflix model, where they will take all of your x-rays and you mail them to them, and they upload all of them for you. So when Netflix started, they said, oh, you have all those CDs, don't worry, you don't have to buy them again, we will upload them to your account. So I think that is actually, they're not the only app out there. There are other companies out there that do that. Green Imaging works with a company as well. So I think we're really getting a lot closer to the patients kind of will travel with those x-rays, and then you'll be able to upload them into your system. I think that's probably the cleanest way to do it. It's again, through our telemedicine, you can upload images, but that's not true for a lot of the telemedicine that is being utilized right now.
Yeah, having electronic medical records speak to each other would be a nice
That's
addition.
not going to happen.
It's never going to happen.
I think what's going to happen first is you're going to get patient traveling with their record, like a cloud-based or a blockchain, and the patient having their own record. That's just the most logical. And then they'd come into your office, barcode it, swipe it, it would upload into your system.
Any other questions, or people want to go live with a question?
Let's see.
I think many of you might be aware about getting multiple state licenses very easily through compact interstate medical license organization. I actually got a license through that to at least quite a few states. And it just, some states you can get it within a couple of weeks. You just need to be licensed in one of the major compact states, and then you can easily get a license. I don't know, the only thing would be some of these states have very expensive, there's a lot of money every few years you have to pay.
Well, you have to pay, and then you also have to do the education and the requirements, right?
Yeah,
So,
that's another issue. Like if the same opiate course was across the board, that would be great, but every state has its own, which is basically the same actually, but still have to pay to update your opiate course.
well, as long as so our platform actually would do that for you, where you would take a course and get it applied to all of the states that it relates to, right? And the same thing goes with human trafficking. There's plenty of states adding that. There's states adding for sexual harassment training. There's a lot of different things, and I'm not going to say they're bad. I mean, there's a lot of good content that people will get out of those trainings. It just becomes cumbersome when you just keep piling it on us and don't give us a solution to fix it. So that's how Mocingbird fits into the puzzle here, to try to ease the burden if we're going to start getting into these types of situations where we're holding multiple licenses.
What about malpractice in multiple states? What is your experience, Dr. Girnita?
I had to search through multiple companies, and I had to use a broker. But finally, I found one company that was able to provide me malpractice insurance in the states where I practice. But I'm more than happy to refer you to this gentleman who was very useful to me, because in the beginning it was a struggle to be approved, and it was before the pandemic. That was another issue. But through the pandemic, things open up. Even the insurance companies, they started to envision ways to cover physicians that wanted to practice in multiple states. So now it might be easier, but you have to ask at least 3 codes to get a good price.
I think Mockingbird or UBERDOC both can negotiate as a company to get with the insurance companies to get a good rate.
We actually, so we had a conversation because that was something we thought was be great, right? UBERDOC could give we can bundle everything together. You get your telemedicine, you get your credentialing, you can get your malpractice and so forth. So the interesting challenge with malpractice is that it's about risk, and they have to assign you a risk category, and that's a group risk, and then it's individual risk, and they don't have a benchmark. So we found out that there were like 35 million telemedicine appointments in the last, prior to COVID, and there were no claims. So now you'd think they should really sell your malpractice for, $1 a month, right? That's for, so it's really interesting that is what they've working from. But we did talk to some companies, but again, they were more concerned about, companies want to group rate if they can assess risk over many people, but they don't have a benchmark. So my guess is that you're going to start to see malpractice carriers in this country offering telemedicine. You already see it state by state, riders and things like that. But most of our malpractice should easily cover telemedicine, right? We're kind of over covered. But I think you're going to see some vendors out there that will offer this. And I think it's just a little early to tell. But I thought it was interesting, 35 million claims. And
thank you to all the speakers. This is wonderful. We had a lot of great conversation on the chat box as well. We're over time, but I would love to give the speakers, there are some questions being asked about, what are Mocingbird, UBERDOCs, and Rheumatologist OnCall. So maybe each of the speaker can give like a quick 1 minute overview of what each of your companies do, and then we can end the call there.
Want to go ahead, Deanna?
Yes, sure. So my company, as you all said, is called Rheumatologist OnCall. It is supposed to be an innovative telemedicine company that wants to introduce direct care and instant access to specialized medicine. The idea behind this practice was to be extremely transparent and affordable regarding cost as well. I wanted to break that barrier for patients that were afraid of the cost to find the good care. And the other thing that I wanted to change through this company was the quality of the consultation. I really am devoted to offer patients quality, not quantity. So that's extremely important for me. And I want to thank you, all of you, for being here, participating in this meeting and inviting me to talk about this. I know direct care is something new in United States, and people are not used to that. How to call a doctor, how to schedule with a doctor, how can I talk to the doctor? But I think this is the way that I envisioned medicine when I was very young. And that's the way that I want to practice. And I know that there are many physicians like me, but they are just too afraid to get out of their comfort zone. And that's all about get out of the comfort zone. And you are, dedicated people that prove again and again that you can achieve many things in your life. You just have to get out of that comfort zone and do something that will fulfill you, and it's good for the others. Thank you.
Thank you.
So yes, thank you for this has been a great evening. So UBERDOC is a direct pay, direct access model. We're a platform that allows a patient to book an appointment with a specialist in person or via telemedicine and pay a transparent price. So we're really very simple. I like to say we're a ticket master. We just, every doctor gives me a couple of seats in their waiting room and we offer them for paying patients. I think every doctor has to have not just a digital practice, they have to have access to, they have to have seats aside for cash pay patients. With the way this world is. And I think this is the way that we're going to survive. I think that what I'm excited about is that with UBERDOC, our network is so large. We build these specialty verticals. We build these, we build this network of doctors that are, they're not all independent. They're mostly independent, but they can be employed as well. We are very inclusive on our platform. We want every doctor in every practice situation to give us a couple of seats. That's all we need is a couple of seats in their waiting room. And then we open to the patients so they have access. We also want doctors to book their own patients through UBERDOC, because how many of us are now without a front end, right? How many of us have had issues because of COVID? Our receptionists don't want to come to the office, right? They don't want to work in the little cubicle. So just accessing is difficult. It's like, just tell your patients, book with UBERDOC. Look at that they're going to be happier. And, and they collect copays. Most of these patients are paying through the nose as it is already. None of their insurance, it really covers what we do every day in the offices, flies under every deductible that's out there. So this is our goal with UBERDOC was to simplify healthcare, make it easy for the doctor, make it easy for the patient. We started this conversation about convenience. This is what patients want, but convenience means easy access, transparent price, and cutting out the nonsense.
Great, thanks. And Mocingbird is a software platform to solve for managing multiple licenses, well as board certification, state, hospital requirements, any type of expirable, and match up curated education for that. So it basically, we pick up where you're credentialing, once you're credentialed, where that leaves off, and we follow you along that journey until you're ready to recertify again. So we fill that gap. I like to say right education, the right place at the right time. So I again want to thank Deanna and Paula for allowing me to moderate this session. I think I learned a ton from the both of you, and I really appreciate the time that you spent here with us.
Well,
Thank you.
in the normal time, we'll give a round of applause to all of our speakers, but since everyone is on mute, we'll give you a silenced round of applause. I will represent everybody, and I want to thank all the doctors on the call. Yes, emoji works, so if you want to just give an emoji claps, that works really well here as well. I want to thank all three doctors, all three great speakers sharing your experience and knowledge with us. I personally learned a lot. I'm still a medicine rookie. I'm still learning a lot from this space. So I have a lot of notes that I can share with my friends and my other doctor friends as well. Again, I want to thank everybody for joining us. Drop questions or information on the chat box. If you would like to reach out to any of these speakers, I'm sure they would love to connect with you as well. So just drop a note. And Dr. Madom, apparently someone is interested in the brand of whiskey behind you.
Oh dear. I have some Whistle Pig behind me and High West.
Appreciate everyone. I know this is pretty late over in the East Coast, friends, so we're gonna let everybody go and enjoy the rest of the night. This is a very special community, and I'm sure that Craig and Satara is going to reach out with more information on UBERDOCs, Mocingbird, and Rheumatologist OnCall. Keep a lookout, and we'll see you next time. Thanks, everybody.
Thanks,
Have a great night,
everybody.
guys.
Take care.
Bye-bye.
Bye-bye.